The way I've done this is just with a series of cases which are kind of made up but kind of representative of the kind of things that we see, just to try and get an approach. So firstly, starting off with a 14-year-old girl who had sudden onset of chest pain while watching TV. She noticed her heart racing, and so her mum called an ambulance. Her observations when the ambulance crew got there was a heart rate of 125, respiratory rate of 25, blood pressure 115/85, normally saturated, with a normal examination, no chest wall tenderness, and nothing focal on the ECG, on the chest X-ray. So an ECG was performed, and is there anything anyone would like to comment about that ECG? You can have a little look there. Yes, feel free to put something in the chat box. So I think if you're just sort of working your way through the ECG, there looks like there is a P wave before every QRS. Maybe the P wave axis is inverted in 3, but it's upright in 1, 2, and inverted in AVR. So it probably looks like sinus rhythm. It doesn't look particularly fast, and they don't look like there's any particular ECG changes. So yes, I think this would pass as a normal ECG for me. So what other questions would you consider asking her if she came into A&E and you were seeing her in A&E? Yep. So this is a sort of one of those things that you learn at medical school, and actually this one stuck with me, and I use this for all types of pain, but obviously chest pain is the thing that we see most often. So sight for this particular child, it was in the left upper chest. Onset, was it sudden onset? Character, it was sharp and stabbing. Radiation, this chest pain hadn't radiated. Any associated symptoms? She said she felt like her heart was racing. Timing, when did it come on? This came on at rest. Are there any exacerbating or relieving features? And she said taking a deep breath in makes it worse. And to give it a score, she gave it a score of 8 out of 10. And I think some of the suggestions in the chat are also very good. Has she recently eaten in terms of reflux being a differentiator? And has she got any background of anxiety? And I agree, they're both very useful things to know. So based on the history that we've got, the ECG we've got, and some of those answers to the question, what do you think the most likely diagnosis is in this setting? And these aren't trick questions. This is just to try and provide a nice sort of way to work through things. Yeah, so I think you know, this is probably a musculoskeletal pain, so as in a non-cardiac pain. It's worse with deep inspiration, and this can be true of something called catch pain, which is probably just a spasm of the intercostal muscles. It's come on sudden, it's stabbingly, and this is very benign and generally just settles with analgesia. And I think that the increased heart rate is just a sinus awareness in relation to her having pain. So I agree, just reassurance, this isn't cardiac. I don't think this is someone that would need referral to cardiology. I think this is one that would be to medicalise as least as possible. So what about if we'd seen this ECG in the patient? What are people's comments on this ECG? And again, you don't have to be precise, just say what you see. So, yeah, there's ST elevation. And what do you think about the ST elevation? Is it focal? Is it widespread? And what might that tell you? Yeah, I agree. This looks like widespread ST elevation. Pretty much every lead looks to be affected, and if it's not got elevation, then it's probably got some depression. And yeah, I'd probably call this saddle shaped as well. So what diagnosis would this be in keeping with? Yep, pericarditis. So pericarditis is relieved by leaning forward. You may have someone that's got some prodromal symptoms, or they may have a systemic illness. Think about other causes. So particularly if you've got patients who might have an underlying condition such as lupus, they could get pericarditis. The mainstay of treatment is non-steroidals, and the characteristic is this sort of widespread ST changes. This is obviously not something we see terribly commonly in paediatrics, and if we do, it tends to be in the older children. And I think generally, if there's a bit of a viral prodrome and they're otherwise well with no hemodynamic effects, then some NSAIDs and safety netting is probably adequate. I think if there's a baseline tachycardia, you've got to be concerned whether there could be a myocarditis involved as well, or if there are any other worrying features. And then you may be thinking more about doing viral screening. But actually, an isolated incident in an otherwise well child, you may well say, give the benefit of the doubt. If, however, they have recurrent episodes, then that may well need further investigation. So what about this ECG? What do you think about this ECG? So same sort of 14-year-old girl coming in with some pain in her chest. What do you think about this ECG? So there is some ST elevation, but it looks different, doesn't it, to the last ECG? And these are sort of relatively common ECG findings that we do see, and probably one of the leading causes of ECGs being sent to us to review. And this is what we call sort of high takeoff or early repolarization pattern, where you've got this sort of high takeoff of the ST segment, and actually you can see here you've got some little J waves as well. And this is something that is generally just considered a normal variant, and it's said to be more prevalent in certain ethnicities, such as African Caribbean patients, but actually you can see high takeoff in children of all ethnicities. And this is something that is generally just acceptable if there are no other worrying signs. So if you've got a very benign sounding musculoskeletal sounding history, no family history, and you see early repol pattern, then you would be quite happy in just calling it that. I think if there's any other concerning features, then sometimes this does, require further investigation. And then this sort of just revisiting this case, but slightly different history. So same sort of 14-year-old girl, and she has sudden onset chest pain while she's running. And she's noticed when she gets this chest pain that she's very pale and clammy, but then she stops running and it all settles. And again, when the ambulance crew arrive, her heart rate's 125 per minute, and otherwise she's got nothing really on examination, and chest x-ray doesn't look terribly exciting. And this is her ECG when she gets to A&E, and those of you that are keen-eyed will notice that it's my same normal ECG, so her ECG in A&E is normal. What else might you ask if she's been brought into hospital by a paramedic crew? Yeah, family history. And is there anything you would ask the ambulance crew themselves, particularly when you've got older children? So one of the things that the ambulance crew are very good at is particularly in the older children, yeah, there we go, is they do an ECG at the scene. And for a lot of patients, actually that's what's going to give you the answer, not necessarily the ECG that you get when they arrive in A&E. So this is the child's ECG that was taken by the paramedics at the scene. And what do you think of this ECG? Yep, I agree. It's not normal. And what part of it do you think is abnormal? Are we talking rhythm? Are we talking axis? Are we talking STs? What part is the bit that concerns you about this ECG? Yeah, I think ST depression, and particularly V4 to V6 are the leads that look concerning. So we do have to remember that although we're paediatricians, we do have to be on the lookout for ischemia. And I think even more so now with the discovery of PIMS TS and the kids presenting with cardiac symptoms related to that. So this is a child who has some episodes, some evidence of ischemia occurring during exercise. and you've really got to consider a coronary issue. Now, of course, children don't tend to get ischemic coronary disease, and therefore you're much more likely to be looking at some form of coronary artery abnormality. So probably the most common one that you will pick up incidentally will be an origin of the left coronary artery from the right coronary sinus. So here you often have two separate coronary arteries, but the left coronary artery comes from the right sinus and then runs between the aorta and pulmonary artery. And there is probably some compression from the pulmonary artery as the pressures go up during exercise, but there is almost certainly an oblique origin and a stenosis at the origin, which is what causes the symptoms. Unfortunately, this often presents as sudden death and a post-mortem finding. However, there are some children that do present with exercise chest pain where this is discovered. Anomalous coronary artery, so left coronary artery coming from the pulmonary artery, is usually picked up in the neonatal period, or the infant period, with heart failure at that stage, but it is possible you could pick something up a bit later on. But I think the main thing is that if you see ischemia on an ECG, then you've got to consider that there may well be a problem with the coronary arteries, and this would therefore merit definitely a discussion with the cardiology team. So just in terms of some benign signs and some red flags for chest pain. So benign signs include that it varies with respiration, that there's chest wall tenderness, and that it comes on at rest or after a big meal. In terms of red flags, if there's a clear relationship to exercise, if there's any syncope, particularly with exercise, and any past history or family history of aortopathy, such as Marfan's or Ehlers-Danlos, as there could be a dissection. If they have had an arterial switch for transposition of the great arteries, as the coronary arteries are manipulated during that operation. If they've had a previous repair of a coronary artery abnormality, for example, Al-Kappa, which is anomalous left coronary from the pulmonary artery, or they've had previous Kawasaki disease, very much so if they've been known to have coronary involvement. And actually to that, we can now add PIMS TS as well. It's also important to note that chest pain is not always chest pain in children, and in the young child it could present with abdominal pain, and in the neonate it may present with inconsolable crying and actually episodes of angina with feeding. So moving on now to look at the palpitation side. So same 14-year-old girl doing an exam at school and noticed her heart beating fast and had difficulty in breathing, and so an ambulance was called. The ambulance crew record a pretty normal set of observations. Examination is normal, chest x-ray is normal, and lo and behold, her ECG is normal. So we then look at the ECG that's done by the paramedic crew, and effectively, other than just showing a slightly faster heart rate, the ECG still looks fine. So what other questions might you ask someone that's presented with palpitations? Yep, the relation to exercise. Has it happened before? Yep, that's very important. Associated symptoms, yep. And I think the key thing as well is onset and offset. So SVTs and arrhythmias tend to be a very sudden offset, and the onset and offset are usually quite sudden. If you have someone whose heart rate slowly speeds up and slowly slows down, that's probably more likely to be a sinus. As you said, ask what you were doing at the time, what did you feel, and are there any other associated symptoms? So in this situation, what would you think the most likely diagnosis is? So it could be SVT, but we've got an ECG of a sinus tachy. And I think this particular girl, I think it's probably much more likely to be a sinus awareness. And this is very, very common. And usually you have sinus on ECG. You've got a benign ECG with no worrying features. It's gradual and offset and onset. You may have an alkalotic blood gas, particularly if they're hyperventilating. It could be associated with syncope. It could be associated with chest pain. And generally speaking, we just offer reassurance and no further investigations. If there's any suspicion that this could be something more than that, then you may want to investigate. If there's a significant anxiety from the child or the family, then you can always do 24-hour tapes, particularly in people that report daily symptoms, as you can then be very reassuring and demonstrate sinus rhythm during their symptoms. So now we've got a slightly different girl. So playing netball at school, she suddenly noticed that her heart sped up. She felt a bit dizzy and stopped, and she looked pale, so the school called an ambulance. By the time she comes to A&E, her observations are normal, examinations normal, chest x-rays normal, and ECG shows this. And what does this ECG show? Yep. And then if we just go into this one, we can just zoom that up, and you can see at first glance you might go, oh, there's bundle branch block. I mean, I think everyone would notice this, the ECG doesn't look normal, but actually what you've got is you've got a short PR interval and a delta wave. So this looks like an ECG that has WPW pattern. So then we ask the ambulance crew for the ECG they did at the time, and this shows a very fast heart rate, it's a narrow complex tachycardia, and sometimes you can spend a long time looking for little P waves, but there aren't really a clear P wave before every QRS. So this child looks to have WPW with SVT associated with that. So what's just have a think. I won't ask people to put things in chat because it's pretty broad reaching, but just have a think about what you do if you had a patient presenting like this. I mean, obviously you would probably discuss with cardiology, but have a think about what's happened to patients that you've seen that have had SVT and what kind of management have they had. So generally SVT is a rapid onset offset. It's not always described as palpitations, and in younger children it can be described as a funny feeling or a fluttering or even chest pain. If the patient presents with cardiovascular compromise, then you follow ABC and APLS guidelines, and obviously if severe compromise, then you would shock. But the majority of children are actually very well with their SVT. If there's no compromise, you can try Valsalva manoeuvres. So Valsalva in children, in older children, get them to blow into a syringe or blow onto their thumb, and in younger children, you can dunk them in ice. If you are cardioverting a patient, whether it's with a Valsalva or whether it's with adenosine, please have a 12-lead ECG running. Adenosine has an exceptionally short half-life, so should be administered with a rapid flush, ideally on a 3-way tap, and you should have the 12-lead running throughout, because it's often you miss if you're just acquiring individual 12 leads, you miss the point of cardioversion, and that point of cardioversion can be really useful for helping in terms of ablation. And in terms of investigations, here we've got documented SVT, so we've really got the information we need. But if, say, we hadn't got documentation of SVT, then we can go through the different investigations which look at the heart rhythm for different periods of time to try and catch the SVT. If it's a first episode and there's no pre-excitation, then we may not treat unless it's in a small child or a neonate, because they can't vocalise when they have SVT. So if you've got a 14-year-old, and often the case is they've come in, had back-to-back nebs for an asthma attack, and then they have a run of SVT, we would not necessarily instigate any treatment if they've got a normal baseline ECG, as there's probably a precipitator. However, if you have a patient who has WPW or pre-excitation on their ECG and they've had an episode, then you would probably at that stage start considering treatment and probably even EP study and ablation. In terms of medical management, we would usually use beta blockers or flecainide or both. Radiofrequency ablation is pretty routine above 15 kilos, and so older children, if they're particularly problematic with their SVT, may be listed for ablation. However, with the small babies, and particularly those that have neonatal SVT, we will often treat with medication for the first year of life and then stop the medication and see if the episodes come back, as they may well not come back. We then would give safety netting and say if episodes last more than 30 minutes, then maybe they can try Valsalva at home, and if no response or they feel unwell, then they can come into hospital. And I think all of these patients would end up seeing a cardiologist at some stage, but this does not necessarily need to be an emergency situation, particularly if the patient cardioverts. So A little bit now on collapse. So we have our same 14-year-old girl. She's receiving the prize for winning the 100 meters. She felt dizzy and weak and then collapsed. She was unconscious for 30 seconds, had some twitching. She was tired and lethargic, and so taken to hospital. So her observations are there. So blood pressure probably on the lower side. Again, examination, chest X-ray, etc. was normal, and her ECG was also normal as a baseline. So what further questions would you ask someone that's come in with an episode of collapse? Yep, family history here is really, really important. Yep, any triggers? Yep, that's very good. Speed of recovery, symptoms prior to collapse, family history of HOCM. Yeah, all of those things are very, very important. So what were you doing at the time? Were you running? Had you stopped running? Had you been standing up for a long time? Had you had breakfast? Is there any prodrome? Are there any flashing lights? Are you feeling dizzy? Was there a sudden fall to the floor or a more gradual collapse? How long was the patient unconscious for? Was there tongue biting, twitching, incontinence? And has this ever happened before? So in this particular girl, what do you think the most likely problem is in this particular girl? So syncope just describes fainting, but what do you think caused this person to collapse? Yeah, I mean, you may well have meant vasovagal when you say syncope. Sorry, yeah. So yes, vasovagal syncope. So this is someone that's just really gone absolutely flat out, and then collapsed, having finished a race, and then collapsed at that point. You are allowed to have twitching. You can have some tongue biting, because in the end, when you have cerebral hypoxia, which is effectively why you faint, then some of the things that may happen with typical seizures can happen too. So typical predisposers are patient where you've been standing, dehydration, low salt intake, and there may well be a prodrome with flashing lights, feeling dizzy, feeling very clammy, or feeling very hot. And then patients may collapse. They can suddenly drop to the floor, or they may have a more gradual drop to the floor. They may well be unconscious for a few minutes and may have some twitching, and then have an almost postictal period afterwards where they feel very weak. Tilt test is not required for the diagnosis of vasovagal syncope. Vasovagal syncope can be diagnosed clinically. The main reason for a tilt test is if you are trying to prove that something is vasovagal syncope as opposed to some sort of malignant arrhythmia, and you haven't been able to do that with your other measures. And the general management is just reassurance, increasing fluid and salt intake. And we do have drugs such as midodrine and fludrocortisone, which may be required in some patients. Generally, often just some conditioning, increasing fluid and salt, and avoiding those predisposing factors are enough. Just a brief word on POTS, so postural orthostatic tachycardia syndrome. This is effectively just an exaggeration of the normal, and it's an awareness of heart rate changes in posture. And this can often be associated with dizziness or syncope, and the management is the same, increasing fluid and salt intake, and very much so improving fitness and conditioning. I had a diagnosis of POTS when I was at medical school, and basically just getting fitter made everything much, much better, and brought my resting heart rate down from about 100 to about 70. And if syncope is a significant issue, then midodrine or fludrocortisone may be required. And I think really the main thing here is to try and avoid the medicalisation of POTS, as this is really just something which is an exaggeration of normal, and there is no serious underlying heart condition. And these patients can obviously often get extremely medicalised, and it's to try and undo some of that. So then we're back to our 14-year-old girl. This time she's running the 100 meters, and 10 meters from the line, she suddenly collapses. She's unconscious for around 30 seconds and she comes round. She's had one previous collapse at home when she was arguing with her mother. Her observations are normal, her examination is normal, chest X-ray is normal, and baseline ECG is also normal. So in this particular sitting, obviously there's a few very subtle key differences to last time. What do you think the diagnosis could be in this patient? And maybe if you say what you think it could be, or say what you, say what's making you think that. So we've got an offer of CPVT, and what features of the history are making you concerned about that? Yeah. So maximal sympathetic stimulation. So I think that's, you've got someone that's mid-race and collapses to the ground. Psychogenic syncope, obviously does happen, but I mean, this is someone that's running absolutely flat out, and it's probably unlikely that they're going to be able to sort of faint at that particular point in time. And this is an example of an exercise test. And I agree, yes, the ECG is against HOCM or critical AS because you've got someone who's got a resting ECG, which is normal. And this is typical of what you would see in an exercise ECG in a patient such as this. So at rest, you've got sinus. After a bit of the exercise test, you start getting what looks a bit like bigeminy, and then you get this really horrible looking rhythm, and then things settle down as you go into recovery. So this is CPVT, which is catecholamine provoked ventricular tachycardia, which is a really nasty polymorphic VT. So the red flags really with collapse is particularly sudden collapses with no prodromes at all. And collapses that happen at times of stress, for example, exercise or arguments. And these can be people that have literally are in mid-argument and then just drop to the floor. And that's obviously a relatively unusual situation. If you think about when people faint with sort of vasovagal, then there's often, they don't just suddenly go in mid-argument. They might go, oh, I feel a bit funny, sit down and then faint. These are people that just literally drop down. And the other thing is about ectopics on an ECG that don't go away on exercise. So if we see patients with ventricular ectopics on an ECG that are frequent, we will always exercise them to check that those ectopics go. If the ectopics go when the heart rate increases, these are likely just benign ectopics that we just follow up if there is a certain percentage burden. However, ectopics that get worse on exercise, you've really got to worry about CPVT. That's been there twice. So just a little bit about family history. So WPW and SVT are not usually hereditary, so we wouldn't worry too much if there was a family history of WPW or SVT, unless there's a particular, it's a particularly unique family with lots of people affected, and we certainly wouldn't screen for them. Channelopathies, CPVT, and cardiomyopathies may all be inherited. And it's very important with particularly cardiomyopathies to know exactly what cardiomyopathy. Is it HOCM? Is it dilated? Is it restrictive? What's the cardiomyopathy? And at what age did it start? And then we would consider screening first-degree relatives. However, if we have a referral because the grandfather has been diagnosed with HOCM, we would not scan the child. We would wait for the parents to be screened before we screen the children. With some of the channelopathies, again, we would usually only really screen first-degree relatives. Aortopathies, Marfan's and vascular EDS, we would all consider screening first-degree relatives or if there are any features, but not the sort of so-called EDS that's associated with hypermobility in POTS, because that's not vascular EDS. Structural heart disease is rarely familial. The chance of having a child with congenital heart disease is increased if you already have a child with congenital heart disease, but it goes from just under 1 in 100 to probably about 1 in 100, so it's still pretty rare. The majority will have fetal echocardiograms, and there is therefore no real reason to do screening for these patients. The only exception is generally a bicuspid aortic valve, when now there is screening, but there's a lot of arguments about screening small children in the absence of murmurs, because it's rarely a problem. If it's not a problem as a small baby, it's rarely a problem until the teenage years. And if you haven't got a murmur, you obviously don't have significant stenosis or regurgitation. And the dilatation that occurs in a bicuspid valve doesn't usually occur until a bit later. In terms of familial hypercholesterolemia, which can cause early onset ischemic heart disease, homozygotes don't usually survive childhood or adolescence, and they're a completely separate category. and heterozygotes develop ischemic heart disease in early adulthood. And these patients should be managed by the lipidologists, who will then refer to cardiology when appropriate. But as paediatric cardiologists, we are not normally involved in these patients at all, as the mainstay of evaluation and management is from the metabolic side. So in summary, cardiac causes of chest pain, even with children with congenital heart disease, are vanishingly rare. Palpitations are common and often benign. Syncope is common, but worrying features include a sudden collapse, particularly in exercise. We've got these little QR codes and the URL there for feedback. I think everyone will be very appreciative of feedback. And I'm happy now if people want to ask some questions in the chat box, and I will see if I can answer them. So it's very difficult doing this whole interaction via a chat box thing, but yes, please feel free to ask any questions, and I think this has been recorded as well. And obviously, I think this talks to the whole sort of London School Paediatrics, so you'll be covered by several different cardiac centres, and every cardiac centre will have, slightly different protocols and guidelines. But I think if in doubt, have a chat with someone from cardiology. A lot of children I will still discuss with Professor Rosenthal here, because I think some children do not always fit the boxes nicely. And I think the main thing really to take away is the history is everything. And actually, for one thing we've learned during COVID was very much that we do a lot over the phone with reassurance without too many tests. So there's a question here about POTS. We don't have a particular criteria. Really, the only children that I would consider treating are those that have got syncope that is interfering with their lives. So we have a couple of children who've got such severe syncope that they faint when they cross the road, or they're fainting multiple times at school and the school are finding it very challenging, or they're missing a lot of school time. And then I'd consider the fludrocortisone, midodrine. I usually do a baseline 24-hour tape, and then you can usually show the family that they actually have good heart rate variation and they don't have a particularly fast heart rate. You may get some children who do have a resting baseline tachycardia, but you are unlikely to get any kind of tachymyopathy unless you've got a heart rate that's sitting, 130 permanently. And generally, these people are usually sitting with heart rate of around 100. So really, it's only probably the syncope that is the main side. And any other questions? Troponin. So I think in the absence of ECG changes and a concerning history, I would not do troponin. There was something I haven't read fully, but I think it's American Academy of Pediatrics have just brought something out about how many investigations we overuse in pediatrics in regards to chest pain, palpitations, and syncope, and troponin was one of them. I find it useful in children where you are maybe worried by the history, or maybe worried by something on the ECG and you want to reassure yourself, or maybe that child with the pericarditic picture and you're a bit concerned, and the troponin might reassure you that there's not a myocarditis. I think at the moment, because of PIMS, everyone's massively scared and we probably do a lot more troponins. I think effectively if a troponin is normal, then that is reasonably reassuring, because I think there are not many cases where you will get a false negative. If it's significantly elevated, it's useful. If it's in the middle, then you probably will just follow the patient up and maybe repeat things. And actually, on looking at things like coronaries on echo now, we have easy access to CT, and we do that a lot more. So I would probably reserve troponin for a select group of patients where there was something that just didn't sit quite right with me. But if the history is benign and the ECG looks normal, I don't think I would do a troponin. Vagal manoeuvres for toddlers and tachycardia at home. I think toddler group are very difficult because I don't think you'll necessarily manage much. You might get some that will blow into a balloon or blow something like that that might Valsalva them, but their toddlers are probably a bit big to dunk in water. We've got a couple of families where they've got quite used to dunking their babies in water and have kept doing it as they get older. But generally speaking, you might end up having to say to the family, look, if they're in it for more than 20 minutes, half an hour, or they're unwell, just bring them into hospital because you might not actually be able to satisfactorily do a vagal manoeuvre in a toddler. Coronary anomalies. So a baseline ECG in a coronary anomaly may be normal, and you may only see changes with exercise. You may see no changes with exercise. If you have something like a missed anomalous coronary, so a missed Al-Kappa that's presenting older, you may have some signs of ischemia. You could have some Q waves. So I think the moral of the story is if the ECG looks normal but the story worries you, then you probably need to image the coronaries anyway. Although remember all of these things are very, very rare, but you might consider doing that. And if you see any ECG changes that concern you of ischemia, then you definitely need to be flagging this as something to look at. And sometimes you find slightly odd things, like I have a patient who's 14 with chest pain and high takeoff of the left coronary artery. And if you look at the adult literature, it's probably a benign finding, but no one really knows. And then you have to work out what you do in that kind of situation. And any other questions? Serial ECGs in A&E. I think it's definitely worth, patients preferably as soon as they hit A&E getting an ECG. And I think if there's anything on the ECG that's a bit funny, then repeating the ECG is worth it. Equally, if they come into A&E pain-free and they develop pain, repeating an ECG then. But I think in the absence of any signs or ongoing chest pain, the ECG will not necessarily change. But what you can do is you can give, particularly with the SVT patients, is you can give parents a letter that says, when I come into A&E, I need an ECG immediately, because often they come in, they sit in triage, and then by the time they get through, they've cardioverted out of SVT. So actually the sort of direct access letters can be very useful. I think if you've got a funny looking ECG, then certainly we've had some patients with sort of evolving T-wave changes, which we have seen on serial ECGs. But I think if you have a patient who has a normal ECG when they come in and they're well and have no further pain, I'm not sure a repeat one will add anything. When should you keep a syncope patient in overnight? My general rule with a lot of patients is if they present, particularly for the first time late at night, then it's often worth keeping them in overnight, just because I never like the idea about sending someone home, particularly the first time episode of SVT or syncope overnight. If they've come in, you've examined them, there's no red flag features, this feels like vasovagal syncope, I think they can be discharged with advice and safety netting. I think if you have someone that comes in and there is a red flag, then I would certainly keep them till you've discussed with cardiology, who then may say, yes, this patient should come over, as an inpatient, or actually, no, you can discharge them and we'll organise these investigations as an outpatient. Because even with something like CPVT, you wouldn't necessarily transfer them as an inpatient. You'd probably get advice to say abstain from any exercise, and then we'll get them in as soon as possible for an exercise test. Indications for regular medication for SVT in neonates. For me, probably any neonate that has an SVT probably needs medication unless there's a clear provoker. So occasionally we'll get called to NICU where a baby's gone into SVT while they're having a long line placed, and that's an obvious provoker because you're poking the heart, in which case I wouldn't treat then. But any neonate that's had an unprovoked SVT or had recurrent SVT should go on medication, as they're the ones that are at higher risk, because A, their heart can go very fast, they could sit with a heart rate of 260, and B, they can't tell anyone they've gone into SVT. So we would pretty much have them all on probably beta blockers as our mainstay. And usually what we do is we leave them, and this includes the fetal SVTs, even if they've not had postnatal SVT, the fetal SVTs all go on prophylaxis. And what this usually is 6 months of increasing it in line with the weight, and then from 6 months to a year, let them grow out of it, stopping it at a year, repeat tapes, and if everything's fine, potentially discharge, but in the knowledge that some children may come back. Okay, so I think that's probably everything now. So, oh, hang on, CPVT, one of the red flags was ectopics on ECG that don't go on exercise. Clarify this. Okay, so obviously ventricular and atrial ectopics are relatively common occurrences when we see patients. If you do a 12-lead ECG and there are multiple ectopics on it, the chances are they're probably happening relatively frequently, because if they've happened enough to see lots on a 12-lead. And then at that stage, would usually do a 24-hour tape to have a look at the ectopic burden. Atrial ectopics are almost certainly benign. Occasionally you may get them associated with an atrial tachy, so take the history very carefully, and the 24-hour tape will help with that. But for ventricular ectopics, our key thing is that we put the children on a treadmill, and we check that the ectopics go away at exercise. So as the heart rate increases, the ectopic burden should go. If the ectopics increase with exercise, then that's very concerning for CPVT. So there's a question here about prophylactic beta blockers for fetal SVT, even if normal newborn ECG. So this is something that could vary from trust to trust, but the Evelina approach is all fetal SVTs will go on prophylactic beta blockers because of the risk of recurrence postnatally. And these are the patients that we would have on beta blockers for the first year of life for 6 months, increasing with weight, and then let them grow out of it, and then stop the beta blockers at that stage. And these would all normally have some degree of follow-up with a cardiologist. Now we will probably see them, start them on medication, do an echo and tape, and then a lot of the rest of it could probably be done with phone consultations until we stop them. Carotid massage, I don't do carotid massage. I think the reason it's a thing in the adults is about carotid stenosis and atheroma and everything. I think it's quite uncomfortable. I'm not sure I even know how to do it properly, and I think in most people you can get them to do a Valsalva, and that's probably as as good, and is much more controllable and something the patient can do without someone sort of hands all over their neck.